clinical practice guidelines for management of glomerulonephritis was published by KDIGO in 2012, and these guidelines have been updated and recently they are published. So the today's topic is on update on the clinical practice guidelines for management of glomerulonephritis. And we have Dr. Amar Sultan, a young dynamic nephrologist from Akola with us to enlighten us on the same. And on the chair, we have Dr. Prakash Khetan, Senior Consultant Nephrologist from Kingsway Hospitals, Nagpur, and Dr. Amit Pasari, an eminent nephrologist from Saraswati Kidney Center, Nagpur. Over to the chair for the further proceedings.
Good evening, everyone.
Good evening, everyone. At the outset, we thank the organizers for giving us this opportunity to share this glomerulonephritis update by Dr. Amar Sultan. I think we are slowly getting new and new molecules to treat various glomerular disorders. Though our standard of treatment is steroids, antimetabolites, and CNIs, and rituximab. Beyond these four, there are very few molecules which we have to treat glomerulonephritis. I think let us listen from Dr. Amar Sultan regarding what is being new as far as the treatment and various diagnostic approach for glomerulonephritis is concerned. Over to Dr. Amar.
Okay, thank you, sir. Yeah, is the screen shared properly?
Yeah.
Yes. Okay. Good evening, everybody. So today's topic of discussion is KDIGO GN Updates 2021. Today, next half an hour, we'll be discussing about the general consideration, IgA, membranous nephropathy, nephrotic syndrome in children, MCD in adults, FSGS, infection-related GN, MPGN, ANCA, and Lupus. So the key differences in 2012 and 2021 GN guidelines are mainly practice point. So as we know, 2012 as well as 2021, they use grade scale. Depending on the level of evidences, they have graded the evidences, and depending on that, recommendations are formed. However, there are gray zones where the evidences are not, systematic evidences are not available. So in those cases, practice points are used. So which are actually not evidence-based, but consensus statements providing guidance for the physician. Apart from this, a few differences regarding the steroids in IgA, and after the Pexivas trial, plasmapheresis in ANCA-associated vasculitis. These are the two major differences. Apart from this, it's very much the revision of the 2012 guidelines. So how do we use practice points? So if there are robust evidences, then we start with the recommendation. And if the robust evidences or the systematic studies are not available, we consider relevant practice points. So coming to the general consideration. So kidney biopsy is the gold standard for glomerular disease. And the places where we can do away with kidney biopsies are steroid sensitive nephrotic syndrome, who are less than 12 years of old, post streptococcal glomerulonephritis, of course with the monitoring of the complements at the end of 3 months. Then apart from this, PLA2R antibody positive, anti-MPY and PR3 ANCA vasculitis, anti-GBM, Alport, Fabry's disease. These are the few examples where we can start with the treatment and can do away with the biopsy. So what is adequacy of the kidney biopsy? It's 8 to 10 glomerulars are needed. A few exceptions where the pathology is diffuse and global. in etiology, like membranous nephropathy, where even a single glomerulus or a part of glomerulus is suffice to diagnose. For FSGS, we may require more number of glomeruli, like 15 or 20. So, while approaching treatment of glomerular diseases, we need to assess the kidney functions. How do we assess it? We assess it with the L for 24 hours urine protein. And in children where particular 24 hours urine protein collection is cumbersome, we go for a spot sample, particularly for the morning. However, we need to keep in mind that a morning sample, we may miss on orthostatic proteinuria. Other method, a way out between a 24 hours urine protein and a spot sample is aliquot, where what we do, we ask patients to collect 24 hours urine protein, and we collect a sample of that collection and go for a protein by create ratio. Management of other complications of glomerular diseases. We use loop diuretic for the management of edema. We restrict sodium intake. Then whenever there is resistance to the diuretics, we go for amiloride or sequential blockade. Then coming to the hypercoagulability and thrombosis in patient with nephrotic syndrome. So patients who have thromboembolic events, a full dose of anticoagulation is required for 6 to 12 months, and the duration of, and for the duration of nephrotic syndrome. Who are those people? Those who have venous thrombosis, arterial thrombosis, pulmonary embolism, or non-valvular atrial fibrillation. Prophylactic full dose anticoagulation should be considered if patient's serum albumin is less than 20 to 25 gram per liter, or proteinuria more than 10 gram, body mass index more than 35, or genetic predisposition for the thromboembolism, or NYHA grade 3 or grade 4 heart failure, recent orthopedic or abdominal surgery, and prolonged immobilization. Where we should not use anticoagulation is patient having bleeding diastasis, central nervous system region who have a risk to bleed, warfaring, metabolism difficulty, frailty, and prior gastrointestinal bleeding. Then management of infection. So those patients, particularly children who have nephrotic syndrome, we advise to vaccinate children with a pneumococcal vaccine. The patient as well as household contact should be vaccinated with influenza vaccine. Herpes zoster vaccine should be given to the patient. And those who are on immunosuppression should be given trimethoprim and sulfamethoxazole prophylaxis for management prophylaxis of infection. For dietary modification, we advise patients to restrict sodium, restrict dietary protein based on degree of proteinuria. We do not advise patient to restrict protein less than 0.6 gram per kg. The protein restriction is up to 0.8 to 1 gram. And then for each gram of protein loss, we add 5 gram per day protein. For those who have CKD, I mean GFR less than 60, we advise patients to get 0.8 gram per kg per day of protein. We advise patients to restrict calories. So those patients who have GFR more than 60, we advise patients to take 35 kilocalories per kg per day, and those with CKD, we advise 30 to 35 kilocalories per day. We restrict fats, dietary fats to less than 30% of total calories, and mono and polyunsaturated fat to less than 7 to 10% of total calories. So management of proteinuria, hypertension, and edema, that includes lifestyle modification, use of renin-angiotensin aldosterone inhibitors, diuretics, anticoagulation, contraception, immunization, like that's what we discussed. In glomerular diseases, blood pressure, management of hypertension, in glomerular disease, the target blood pressure is less than 120 systolic. For children, mean arterial blood pressure should be less than 50th percentile. General considerations are salt restriction, weight normalization, regular exercise, and smoking cessation. First line of antihypertensive are RAS blockade, and the second line we consider mineralocortical receptor antagonist. Apart from this, calcium channel blocker, beta blocker, or alpha blocker like central alpha blocker like we do use. So coming to the first glomerular diseases, IgA nephropathy. So IgA dominant glomerular nephritis. So we first rule out secondary causes like IgA vasculitis, IgA secondary to viral infection, inflammatory bowel disease, cirrhosis of liver. Then we consider IgA and nephropathy. Calculate the score using kidney biopsy, MES-C score, risk stratification. Then we offer supportive care like blood pressure management, maximum tolerated RAS blockade, lifestyle modification, and then address cardiovascular risk with weight reduction. This is again international IgA prediction tool where we stratify the risk associated with IgA progression, which include estimated GFR, systolic blood pressure at the time of biopsy, diastolic blood pressure, proteinuria, age, race, MES score, and immunosuppression. However, many times during prognostication, MES score individually and Oxford classification have been found not to correlate significantly. So management of IgA. All patients with IgA nephropathy, supportive care are advised for more than up to 3 months. And those with proteinuria of more than 2.4 gram and high risk of progression, that is decrease in high risk of progression depending on the IgA tool, may be offered immunosuppression. So immunosuppression in the form of glucocorticoid for a duration of 6 months, or however, we need to be careful while using glucocorticoid as suggested by Stop IgA and testing trial. And we need to be vigilant and discuss with the patients about the risk involved in glucocorticoid. Particularly those patients who have GFR of less than 30, those who are diabetic, with obesity, having latent infection, secondary diseases, acute peptic ulceration, uncontrolled psychiatric illness, and severe osteoporosis. It is not advisable to consider glucocorticoid even in those with a progressive diseases. So other therapies in IgA, antiplatelet, anticoagulants, azathioprine, CNI, cyclophosphamide, rituximab, fish oil are not recommended. MFF, there is a small RCT that has shown some benefit of mycophenolate in Chinese population and benefit of hydroxychloroquine in Chinese population. In Caucasian and these people, MMF and hydroxychloroquine are not advisable. Tonsillectomy is advisable in Japanese patient. So a special consideration for the IgA with NS should be managed as a minimal change disease. So that is to be treated with steroid in adult as well as children, how we manage minimal change disease. So those with MPGN pattern with significant mesangial IgA deposition should be managed as an MPGN pattern. So IgA with AKI, repeat kidney biopsy is advisable if there is no improvement after 2 weeks following cessation of hematuria. This AKI may represent rapidly progressing glomerulonephritis in absence of hematuria if we exclude other causes like ANCA-associated vasculitis, drug, or other causes for acute kidney injury. So IgA nephropathy with RPRF, the definition of RPRF is more than 50% decline in GFR in 3 months. To diagnose RPRF, biopsy is essential. On biopsy, mere presence of crescent in absence of reduction of GFR does not mean rapidly progressive disease and should only be offered supportive treatment. Those with RPRF, a patient should be treated with steroid and cyclophosphamide. IgA in pregnancy. IgA in pregnancy is a young adult child of childbearing age group. So preconception counseling should be offered to all the patients, as we need to stop RAS blockade in those women who are high risk of progressive CKD. Despite maximal supportive care, a trial of immunosuppression to optimize immunological activity and reduce proteinuria prior to conception should be offered rather than emergent initiation of immunosuppression during pregnancy. It's important. IgA nephropathy in children. To define children, we consider people of less than 18 years. So in children, hematuria is more common. They should be offered RAS blockade if there is protein creatinine ratio of more than 200 milligram per day or proteinuria more than 200 milligram per day. BP control should be offered to less than 90 percentile. They should be offered low sodium diet. Immunosuppression, steroid of 1 to 2 milligram per kg per day for 4 weeks, followed by alternate day steroid with tapering for up to 4 to 6 months. How we treat nephrotic syndrome in children. They are required long-term follow-up because they may relapse even after years. IgA nephritis in adults. So in nephritic, uncontrolled hypertension and proteinuria are poor kidney outcome. No validated prognostication tool, that is both MES score and as well as Oxford classification, have not been validated for progressive diseases in IgA adult. Prophylactic steroids are not recommended to prevent nephritis in IgA or associated vasculitis. Next, in membranous nephropathy, a kidney biopsy is not indicated to confirm the diagnosis if the patient has anti-PLA2 or antibody test positive. The patient with membranous nephropathy should be evaluated for associated condition regardless of whether they are anti-PLA2 or positive or not. They should be screened for malignancies, that is population and age appropriate screening. Chest X-ray to rule out sarcoidosis, history of drug intake, anti-nuclear antibodies, viral infections. Ultrasound of the kidney should be done to rule out, and a history of the systemic diseases and thyroid diseases should be taken. Risk assessment in membranous nephropathy. So depending on level of proteinuria, membranous nephropathy are classified as low risk, moderate, high risk, and very high risk. So those with normal GFR and proteinuria less than 3.5 gram per day are considered as low risk. Moderate risk are normal GFR and a proteinuria of more than 3.5 gram and no decrease of more than 50% after 6 months of conservative therapy. Then high risk are GFR less than 60 ml per minute and proteinuria of more than 8 gram, or a normal GFR or proteinuria of more than 3.5 gram per day and no decrease of more than 50% after 6 months of therapy. And at least one of the following, which includes serum albumin less than 25 gram per liter, PLA2 or antibodies of more than 15 RU per ml, and very high risk life-threatening nephrotic syndrome, that is thrombotic complications or rapid deterioration of the kidney functions are not otherwise explained. Treatment of membranous nephropathy. So those which are low risk, we offer supportive management. Those with moderate risk, we offer supportive management for 6 months, and then if there is no decrease in proteinuria, we offer patients we treat them with rituximab, calcineurin inhibitor or glucocorticoid. Those with high risk, we offer them cyclophosphamide or glucocorticoid modified Ponticellin regimen or rituximab and steroids. There are trials who have shown calcineurin inhibitor to be effective in low risk as well as but not as effective as cyclophosphamide and steroids. Sorry. And those with very high risk should be offered cyclophosphamide and glucocorticoids. Then how do we monitor membranous nephropathy? So at the end of 6 to do it at the 3 months. So we do PLA2 or antibodies. Those who have PLA2 or antibodies are abstained. And those who have been treated with rituximab, we do not give additional rituximab. And those who have been treated with cyclophosphamide and glucocorticoid, we stop cyclophosphamide and glucocorticoid. And we taper slowly calcineurin inhibitors with 0.25 milligram every 3 months. Those who have anti-PLA2 or present, antibodies present at the end of 6 months, we continue rituximab with 2 gram. Cyclophosphamide and glucocorticoid, we stop cyclophosphamide and glucocorticoid and we add rituximab to the therapy. Those who treated with calcineurin inhibitor and prednisolone, we taper calcineurin inhibitors and we add rituximab or cyclophosphamide. Anti-PLA2 are present but decreased. And if the patient is on rituximab, we continue with rituximab. And if the patient is treated with cyclophosphamide and glucocorticoid, we stop cyclophosphamide and we observe. For those who have been treated with calcineurin inhibitor and prednisolone, we continue calcineurin inhibitors for another 6 months. For treatment of relapse, we treat patients, those who have been treated initially with rituximab, we repeat rituximab. For calcineurin inhibitors, we add rituximab. For cyclophosphamide, either cyclophosphamide or glucocorticoid, or we treat them with rituximab. For management of resistant cases, and if the patient, the first failure line, if the patient has been treated with rituximab, cyanide, and cyclophosphamide, the patient has stable GFR, we consider switchover therapy, like either of the class change. Like suppose if the patient has been treated with rituximab and if GFR is stable, we can consider calcineurin inhibitor. For similarly, if the patient is treated with CNI and GFR is stable, we can consider rituximab. However, if the patient is having decreasing eGFR, we shift patient to cyclophosphamide and glucocorticoid. For transplant consideration, if the patient has anti-PLA2 or antibody positive, there are high risk of recurrence after post-transplantation. However, the risk of recurrence is still considered, the benefit of transplantation outweighs the risk involved in the recurrence of the disease, and we still consider patient for transplantation. If the recurrence post-transplantation, we monitor proteinuria every month. If the proteinuria is less than 1 gram, we observe. If the patient, we start patient on RAS blockade. If the proteinuria is less than nephrotic range. If the proteinuria is further at the end of 3 months, if the proteinuria is persistent, we think of adding rituximab in addition to RAS blockade and strict adherence to the immunosuppressive therapy. Membranous nephropathy in children, no evidence as such to present guide management of children in children with MN. We treat them as nephrotic syndrome along with steroid and and calcineurin inhibitor and rituximab. Anticoagulant in membranous nephropathy. Prophylactic anticoagulant therapy in patient with membranous nephropathy and nephrotic syndrome should be on an estimate of the risk of thrombotic event and risk of bleeding complication. So those patients who have serum albumin of less than 20 gram per liter, we assess bleeding risk. If the patient's bleeding risk is high, we consider them for aspirin. If the bleeding risk is low, we consider them for warfarin or low molecular weight heparin. If the patient albumin is more than 2 gram but less than 30 gram per liter, then we consider, and if the risk of thrombosis is high, we consider aspirin. If the risk of thrombosis is less, we do not offer them any anticoagulant. This is again the assessment of risk of thrombosis and bleeding. This is available online, where we consider age, sex, race, serum creatinine, serum BUN, albumin, hemoglobin, and what benefit to risk ratio we consider acceptable, like 2:1, 2 VTA prevented for 1 major hemorrhage occur. The nephrotic syndrome in children. So by definition, as we consider in adult, proteinuria more than 3.5 gram per day as a nephrotic range proteinuria. For children, we consider a PCR of more than 2 gram per gram of creatinine, or more than 40 milligram per meter square per hour, or 50 milligram per kg per day. Apart from this, we do have a definitions like frequently relapsing, infrequently relapsing, steroid resistant. There is a difference between 2012 guideline and 2021 guideline, where the definition of steroid resistance was 8 weeks, no response to steroid after 8 weeks. Here they have considered no response to steroid for 4 weeks. Late responders, they have considered steroid, no response to steroid after 6 weeks. So NS in nephrotic syndrome in children, we recommend that glucocorticoid given 8 weeks is 4 weeks of daily glucocorticoid followed by 4 weeks of alternative glucocorticoids. And prevention of treatment of relapse in nephrotic syndrome for those who are children with frequently relapsing and steroid dependent nephrotic syndrome, who are on alternative glucocorticoid and off glucocorticoid, we recommend that daily glucocorticoid of 0.5 milligram per kg be given during episodes of upper respiratory tract and other infections for 5 to 7 days to reduce the risk of relapse. For children with frequently relapsing nephrotic syndrome who develop serious glucocorticoid related adverse effect, and for all children with steroid dependent nephrotic syndrome, KDIGO recommend glucocorticoid sparing agent rather than no treatment or continuation of glucocorticoid treatment. Sparing drug, cyclophosphamide, levamisole, CNI, rituximab, and MMF. This rituximab is the new addition. Initially, the use of rituximab wasn't graded. Even there are no RCTs per se for use of rituximab in steroid dependent nephrotic syndrome. However, this is the new addition. So cyclophosphamide is we offer with a 2 milligram per kg per day with cumulative dose of 168 milligram per kg. Levamisole, we consider 2.5 milligram alternate day for 1 year. CNI, either tacrolimus or cyclosporine, depending on the cosmetic side effects. Then rituximab, the dose further of the rituximab is not well defined. However, 375 milligram per meter square, 4 doses have been recommended. MMF again, 1500 milligram per meter square, and to be given for minimum 1 year. For treatment of steroid-resistant nephrotic syndrome, we recommend using cyclosporine or tacrolimus as initial second-line therapy for children with steroid-resistant nephrotic syndrome. Again, cyclosporine in the dose of 3 to 5 milligram per kg to be offered for 6 months. If there is no response in 6 months, we should consider alternative therapy. If there is response, it should be continued for 1 year after the remission. The tacrolimus, the dose is 0.1 milligram per kg in 2 divided doses. So when do we go for kidney biopsy? If the nephrotic presentation age is more than 12 years of age, steroid-resistant disease, high index of suspicion of different in underlying etiology. Then those who are considered for steroid therapy should be offered vitamin D and calcium supplementation. Gastroprotection have not shown any benefit. So this is again the definitions of nephrotic syndrome in adults. We call it complete remission when there is a reduction in proteinuria of less than 3 gram per day or a protein create ratio of less than 300 milligram per gram. Partial remission when there is a reduction of proteinuria to more than 50% on proteinuria between 0.3 gram per day to 3.5 gram per day. Relapse when there is recurrence of the proteinuria to more than 3.5 gram per day. Steroid resistant when there is no response to steroid after 1 milligram per kg per day of steroid for more than 16 weeks. Frequently relapsing when there are 2 or more relapses per 6 months or 4 or more relapses per 12 months. Steroid dependent may, when relapse occurred during or within 2 weeks of completing glucocorticoid therapy. KDIGO recommend high dose of glucocorticoid therapy for initial treatment of minimal change disease, and that has to be given minimum 4 weeks to 16 weeks depending on the remission. If, the steroid 1 milligram per kg per day to be continued for 2 weeks after complete remission and slowly tapered over the period of 6 months. For those who with glucocorticoid are relatively contraindicated, it should be considered with cyclophosphamide, CNI or MMF. So steroid dependent minimal change disease, those who are frequently relapsing, steroid dependent and no exposure to a cyclophosphamide should be considered for cyclophosphamide, and those who have received cyclophosphamide initially should be considered for rituximab, calcineurin inhibitor or mycophenolate mofetil. So for FSGS, it is advisable to rule out the secondary causes. How do we differentiate secondary FSGS? So those who are having nephrotic range proteinuria, however serum albumin is more than 3 gram, or with a proteinuria of less than 3.5 gram with or without hypoalbuminemia. And on electron microscopy, there is history of diffuse food process flattening. There is no diffuse food process flattening. The causes of secondary FSGS are viral infections like HIV, CMV, parvovirus. Drug induced, it could be like mTOR inhibitors, CNI, anthracycline, heroin, lithium, interferon. And secondary to adaptive changes with glomerular hypertension like reflux nephropathy, renal dysplasia, sickle cell disease, and or age-related FSGS. The normal nephron number like obesity-related glomerulopathy, primary glomerular disease, or systemic diseases like diabetic nephropathy or hypertensive nephrosclerosis. The treatment of focal segmental glomerular sclerosis in adult. So KDIGO recommend a high dose of oral glucocorticoid to be used as a first-line immunosuppressive treatment for primary FSGS. And that has to be considered for a maximum period of 16 weeks or complete remission, whichever is earlier. So we treat patient for 6 weeks. If there is no remission or partial remission, we consider 6 more weeks. And if there is no remission at the end of 12 weeks, we consider giving 4 more weeks of 1 milligram per kg of steroids. And the adults who respond to steroid should be given glucocorticoid for more than 6 months with tapering, more than or equal to. In adults with relative contraindication for glucocorticoid, alternative immunosuppression in the form of CNI should be offered as initial therapy. So focal segmental glomerulostomia in adult, we offer high dose steroids and CNI in the either tacrolimus or cyclosporine. This is the same for steroid resistant FSGS. We consider adding a cyclosporine or tacrolimus for more than 6 months rather than continuing glucocorticoid monotherapy. The new topic is infection-related glomerulonephritis, which contain post-infectious glomerulonephritis, shunt nephritis, endocarditis-related glomerulonephritis, and IgA dominant infection-related glomerulonephritis. The point that is to be highlighted, the treatment is aimed at the underlying process, underlying disease rather than, and there is no role of immunosuppression. The immunosuppression was initially tried in IgA dominant infection-related glomerulonephritis. However, there was no benefit, and only the treatment of underlying infections has been advised. For virus-related GNS like for HCV, HBsAg, and HIV, the treatment of underlying disease or the virus is offered. For HIVAN, apart from heart, consideration of steroid may be offered, but however, the risk and benefit needs to be discussed with patient. Coming to MPGN, unlike the initial classification of MPGN where the class 1, class 2, class 3, now MPGN is considered the pattern of injury, and depending on the deposition, whether it is immunoglobulin or complement, we divide it immunoglobulin deposition diseases and the complement mediated MPGN pattern. So with immunoglobulin deposition, we do have monoclonal gammopathies, infection-related and autoimmune diseases and idiopathic. On complement dominant, we have C3, C4 glomerulonephritis and dense deposition disease. And the MPGN pattern of injuries who do not have immunoglobulin or complement deposition, we do get them in antiphospholipid antibody syndrome, HUS and TMA, sickle cell anemia, and polycythemia. In MPGN treated, those who have heavy chain deposition disease or multiple myeloma, we consider treatment of underlying etiology. If the patient does not have nephrotic range proteinuria, we treat them with supportive care in the form of controlled blood pressure, low sodium diet, and offering glass blockade. If the patient has nephrotic range proteinuria, we consider steroid. If the patient has crescentic GN, we consider steroid plus immunosuppression in the form of cyclophosphamide. For C3 GN, we consider patient to be treated with steroids and mycophenolate plus, and if it fails, we consider adding eculizumab. Coming to ANCA vasculitis. So, in case of clinical presentation, and if we have anti-ANCA, anti-PR3 or anti-MPO positivity, instead of a biopsy and confirmation of diagnosis on the biopsy, we may proceed for the treatment, and then when feasibility, we consider for biopsy. KDIGO recommend use of glucocorticoids in combination with cyclophosphamide or rituximab as initial treatment of new onset and ANCA-associated vasculitis. So, after the diagnosis of ANCA-associated vasculitis, we assess disease assessment is done, and then induction regimen in the form of cyclophosphamide plus glucocorticoid or rituximab plus glucocorticoid is offered. If the patient has low risk of life, no organ threatening involvement, mycophenolate may be considered. And those with vital organ or life-threatening infection and the serum creatinine of more than 5.7 milligram per deciliter creatinine, we may consider plasmapheresis. Once the disease is controlled, we offer patient to maintenance in the form of azathioprine and glucocorticoid. And those who have been initially treated with rituximab and glucocorticoid, we may consider maintenance with rituximab, and we may taper glucocorticoid. When we consider induction with rituximab and cyclophosphamide, so rituximab is preferred in children and adolescents, premenopausal women and men concerned about who are concerned about their infertility. Then frail older adults, glucocorticoid sparing, especially important. Then relapsing disease and anti-PR3 ANCA disease. Cyclophosphamide is preferred in rituximab, difficult to assess. When rituximab is difficult to assess. Then severe glomerulonephritis, that is serum creatinine of more than 4 milligram per deciliter, and combination of 2 intravenous pulses of cyclophosphamide with rituximab can be considered. Discontinue immunosuppressive therapy after 3 months in patients who remain on dialysis and who do not have any extrarenal manifestation of diseases. After the Pexivas trial, initially we used to use steroid as in nephrotic syndrome, where we used to continue 1 milligram per kg steroid for 6 weeks and then gradually tapering. However, after Pexivas trial, even the low dose steroid have been found to be effective, and we consider rapid tapping of steroids and continue it of 52 weeks, at least for 1 year. And then after 1 year, it's an investigation local practice whether how he wants to continue steroids. So what are the immunosuppression in ANCA? Vasculitis, oral cyclophosphamide, that is 2 milligram per kg for 3 months. And we continue it for a maximum of 6 months if the disease activity is persistent. Intravenous cyclophosphamide, where 15 milligram per kg at 0, 2, 4, 7, 10 and 13. That is 6 doses. Rituximab, we offer 375 milligram per meter square, 4 doses, or 1 milligram at 2 doses, 15 days apart. This is again a rituximab and IV cyclophosphamide combination therapy, where we give a rituximab 375 milligram, 4 doses, one dose per week for 4 doses, and then IV cyclophosphamide for 2 doses, or 1 gram rituximab, total 2 doses, and then 500 milligram every 15 days for total 6 doses. Mycophenolate, 200 milligram per day, and the dose of which may 3 gram per patient for a poor response to the therapy. When do we consider plaques in ANCA? So initially, we used to consider the moment ANCA is diagnosed, we used to consider patient along with immunosuppression, we used to consider patient for plaques. So after Pexivas trial, we consider plasma exchange for patient with serum creatinine more than 5.7 milligram per deciliter requiring or rapidly increasing serum creatinine, and patient with diffuse hemorrhage who have hypoxemia, or those who have overlap syndrome in the form of ANCA vasculitis and with anti-GBM syndrome. And those who have received induction, recommend maintenance of and low dose glucocorticoid after induction of remission. So, while maintenance therapy in ANCA, those who have received induction with cyclophosphamide, either azathioprine plus glucocorticoid or rituximab without glucocorticoid should be used. Those who have received induction with rituximab, maintenance immunosuppressive therapy should be given to almost all patients. The optimal Hello? Hello?
Yeah, Amar, go on.
Yeah, okay. Yeah, can you see it? Hello?
Amar, your voice is audible, but your screen is not visible.
Is it seen now? Hello?
Yes, yes.
Okay. So coming to systemic lupus erythematosus, so patient who are diagnosed with systemic lupus erythematosus And those who are having active sediments on urine and proteinuria of more than 500 milligram per gram, 500 milligram per day or 500 per milligram per gram of creatinine should go for kidney biopsy. Other than that, there is always a conflict between the rheumatologist and nephrologist whether to go for a kidney biopsy or straight away start for the kidney biopsy immunosuppression. So what those KDO recommend a patient with SLE, including those with lupus nephritis, be treated with hydroxychloroquine or an equivalent anti-malarial unless contraindicated. The adjuvant therapies in lupus includes cardiovascular risk modification, that includes lifestyle modification, smoking cessation, body weight optimization, dyslipidemia management, and low dose aspirin during pregnancy. Then avoidance of high sodium diet, blood pressure control, RAS blockade. Then to control infection, active immunization as previously described for nephrotic syndrome. Then bone injury, bone mineral density and fracture risk assessment, calcium and vitamin D supplementation, and bisphosphonate when appropriate. Then premature ovarian failure, so gonadotropin releasing hormone agonist, and sperm and oocyte cryopreservation. So those with class 1 and class 2 lupus nephritis, if those they have low level proteinuria, immunosuppressive treatment should be guided by extrarenal manifestation of systemic lupus erythematosus, and those who have nephrotic syndrome, they should be evaluated for lupus podocytopathy and should be treated as minimal change disease, that is with steroid. Those with active class 3 and class 4 lupus nephritis with or without membranous component, they should be treated with glucocorticoid plus a low dose intravenous cyclophosphamide or mycophenolic acid. A regimen of reduced dose glucocorticoid following a short course of prednisolone pulses may be considered during the initial treatment of active lupus nephritis when both the kidneys and external disease manifestations show satisfactory improvement. So as initially again, high dose steroid, now the standard dose scheme, moderate dose scheme, and reduced dose schemes are there, where the methylprednisolone intravenous pulses are reduced to 250 milligram, 250 milligram to 500 milligram per day for 3 days, or 0.25 or 500 milligram steroid, and followed by rapid tapering. Apart from this initial induction, there are further tapering where we taper to 50 milligram in 1 week, and then again 5 milligram every 1 week. That table I have not included here. So those with for lupus, intravenous cyclophosphamide should be used as initial therapy for active class 3, class 4 lupus. Mycophenolate based regimen is preferred initial therapy for proliferative lupus nephritis for patients who have a risk of infertility or patients who have moderate to high prior cyclophosphamide exposure. Then, or those with African ancestry. Initial therapy with a triple immunosuppression regimen that includes CNI, low dose mycophenolate or glucocorticoid is reserved for patients who cannot tolerate standard dose MPA, or class 5 lupus nephritis, that is China, class 3 plus class 5 or class 4 plus class 5 lupus nephritis, that is Chinese regimen. A patient with baseline GGFR of at least 45 ml per minute per 1.73 meters square, oclosporin can consider in addition to mycophenolate or glucocorticoid. There is emerging role of beta lymphocyte targeting biomolecules. Belimumab can be added as to standard therapy in the treatment of active lupus nephritis. Rituximab can be considered. Other therapies such as azathioprine or leflunomide combined with glucocorticoid may be considered in lieu of recommended initial drug for proliferative lupus nephritis. Induction therapy, those with class 3 and class 4 should receive maintenance therapy either with azathioprine or mycophenolate methylprednisolone. Glucocorticoids should be tapered to a lowest possible dose during maintenance, except when glucocorticoids are required for external lupus manifestation. The dose of mycophenolate is approximately 540 to 720 milligram twice a day. And if MPAA or azathioprine cannot be used as maintenance, mesoribin can be used. The total duration of initial immunosuppression plus combination of maintenance immunosuppression for proliferative LN should not be less than 36 months. For the treatment of relapse, after a complete or partial remission has been achieved, LN relapses should be treated as the same initial therapy used to achieve the original response or an alternative recommendation recommended first line. So those who have treated with mycophenolate and steroid can be treated with cyclophosphamide, or those who have received cyclophosphamide can be treated with MM. So patient with active lupus should not be counseled to avoid pregnancy while the disease is active, and they can go ahead with the pregnancy only if the disease is in remission for more than 6 months. To reduce the risk of pregnancy complication, hydroxychloroquine should be continued during pregnancy, and low-dose aspirin should be started before 16 weeks of gestation. Glucocorticoid, hydroxychloroquine, azathioprine, and CNI are considered safe immunosuppressive in pregnancy. Thank you. So compared to 2012 guideline, the differences in 2012 and 2020 were practice points, those were added. And the role of rituximab that was highlighted compared to endoxan, in particular steroid dependent cases. And after the Pexivas trial, the plasmapheresis was restricted only if the creatinine was more than 5.7 or if the patient has pulmonary hemorrhages or hypoxia. So these were the distinguishing point particularly.
You mentioned the various frequently relapsing steroid sensitive, steroid responsive. Those
Yes,
definitions
sir.
only apply for pediatric patients, not for adult patients.
So, but adult also, sir,
All
we
the
treat them
definitions
with
which are there for minimal change disease, steroid responsive, steroid frequently relapsing, steroid resistant, all these are applicable only to pediatrics, not to adult population.
Okay.
We do not use this terminology for adult NCD.
Okay.
Adult NCD can be steroid responsive or steroid resistant. That's the only two definitions, I think.
Okay.
Any more comments from anyone or any questions? I think Amar has done a fantastic job in covering a vast glomerulonephritis in just 45 minutes to an hour of his deliberation. If somebody has different views or some different experience, I think we can here have a formal discussion.
I think Saurabh has a question. Dr. Saurabh Lande.
Sir, very good evening to all respected members. I just wanted to...
Hello? Hello?
Of CGN, where the baseline crate is somewhere around 1.5 to 1.7, 1.8. On immunosuppressions, what should be the normal dose of proteinuria that we should consider that patient is in remission? Because somewhere I have a patient with CGN with creat of around 1.7, his 24 urine protein ranges between 600 to 700 mg per day. So should I be happy or should I target it lowering down more than that? I want to know the comment from sir.
Hello?
Hello?
I think Saurabh has asked whether proteinuria of 600 to 700 milligram in a patient with CKD whose creatinine is around 1.5 to 1.7, should we target a lower proteinuria? That's the question?
Yes, sir. Yes, sir. Yes, sir. Yes, sir.
So we can go on increasing RAS blockade as much as we see. If as long as it's less than 1 gram, it's acceptable. But we can still go on maximizing the RAS blockade, the supportive care, like the blood pressure management. We can add certain, and we can consider maximum. We can, in fact, we can consider adding dual RAS blockade also if the patient is not diabetic.
So dual large blockage. Okay.
If the patient is not diabetic. I'm sorry, when there are like the voice was breaking, I wasn't able to hear what exactly the etiology of the CKD was. CGN was.
So, is there a data for a dual RAS blockade in patients who are not diabetic and have been shown to have benefit?
Ma'am, retrospective studies are there. Even in membranous nephropathy, particularly, even a dual RAS blockade, the prospective randomized control trials have not been done, though. But dual RAS blockade can be offered in glomerular diseases for the control of proteinuria in non-diabetic patients.
I think there were a lot of studies before Salim Yusuf study regarding combined usage of ARB and ACE inhibitors in various proteinuric nephropathies and even in diabetic nephropathy. But after that trial of Salim Yusuf, I think nobody has done a trial on combining the two together. There are no trials after that study.
So the prospective trials are not there. Retrospective studies are there for a dual RAS blockade in membranous nephropathy, particularly. Even KEM has a data of retrospective studies, but no prospective data.
The retrospective study, the
level of evidence is
not taken as a very high level of evidence. No?
High level evidence.
That's the reason retrospective studies, I don't think they take it as a high level of evidence.
Yes, sir. Yes, I completely agree, sir.
So this is a question to Dr. Khetan, sir. Sir, what is your experience of using rituximab in steroid-resistant FSGS and in membranous?
FSGS I have not used much, but membranous I have few patients, but there is mixed response. Like a few of the patients had shown very good response and have undergone remission, but few of the patients did not respond even after giving rituximab, especially elderly people. And minimal change disease, yes, they do respond, but again they come back with relapse. They require steroids again. Like they do respond. I have few MCD also. FSGS I have not used rituximab as yet. But minimal change disease, steroid dependent or frequently relapsing, in those I have used rituximab with a good result. But then later on they came back again with relapse. Like they did not remit for had a prolonged remission was not there. They came back with relapse after some time.
You have used 4 doses or 2 doses?
4 doses.
4 doses.
All the patients received 4 doses.
FSGS patients generally do not respond to rituximab, sir. We also have 3-4 patients who were resistant to all other therapies, cyclosporine, steroids. So we tried rituximab, but none of them had a remission.
I have not used in FSGS because FSGS otherwise also are bad patients.
Bad disease.
Good response in a few this vasculitis like crescentic GN with some very good response with rituximab. The creatinine normalized. Proteinuria persisted, but the creatinine normalized. ANCA associated GN also good results with the rituximab.
So the use of SGLT2 inhibitors in IgA is not incorporated in the revised guidelines. Is it there or not?
It is there. It is there now. IgA, we are about to get enrolled in a trial of IgA nephropathy, wherein they have permitted use of SGLT2 inhibitors. If the patient is already on SGLT2 inhibitors and has got IgA nephropathy, they are okay with it. So that means it is an accepted guideline.
So is it there in 2021 update? Has it come?
I think Amar has, no, it has not come in these guidelines. KDIGO guidelines have not given use of SGLT. If we go by KDIGO, no. But if we go by those studies and recommendation, then we can, yes.
Sir, hello, sir.
Yeah, Prashant.
Yeah, sir, there was actually in IgA, budesonide was, I think, used for treatment, oral budesonide, I think, in the trials.
Yes, yes.
So I just want to ask, like, these trials, like, even in the KDIGO, have they mentioned about the use of budesonide, particularly as a steroid?
KDIGO doesn't mention use of budesonide. I think these are not high-level evidences. That's why KDIGO has not included it.
Because that was a particular steroid which was effective in IgA. I think
maybe few anecdotal studies or uncontrolled studies wherein the level of evidence might be very big. That's why KDIGO has not mentioned it, I think. Amar, did you come across budesonide in IgA?
Sir, KDIGO hasn't covered it. But 2 years back, ASN highlights, they had mentioned about the use of oral budesonide, particularly in powder form, for the treatment of IgA nephropathy. And they had shown good results. However, it was, I guess, observational study only. But
any of us have used, I haven't used the budesonide. Oral budesonide, I have not used any time. Anybody of us has used? Is it available, oral budesonide?
No, sir. Only one talk I came across about budesonide was in ASN highlights.
Okay. Recently, we had that ASN highlights a couple of weeks back.
Another things are like I had one patient who is having post-transplant recurrence of FSGS. He's responding to the plasmapheresis. Rituximab was also given in the guideline. I don't know anybody has used in that context rituximab in recurrence of FSGS post-transplant.
Yeah, rituximab as well as plasmapheresis have shown benefits in recurrence of FSGS, both of them.
I think it requires a very aggressive treatment as far as post-transplant FSGS is concerned, recurrence. So I think we have to use all our guns. So plasma as well as the rituximab will be required to control the disease.
Okay, sir.
So if there are no questions, we can request Sureshri and Vishal to take over.
So Vishal, could you propose vote of thanks?
Yeah. So thank you, Amar, for that extensive coverage of the recent glomerulonephritis guidelines. I would like to thank the chairpersons for tonight, Dr. Prakash Ketan sir and Dr. Amit Pasari sir. And I would like to thank all the attendees who have attended and participated in today's meeting.